am Dr. Dilip. I am working as a consultant nephrologist at Apollo Hospital, Hyderabad. Good morning, students. Today we are discussing about diabetic nephropathy. As we all know that nowadays incidence and prevalence of diabetes is day by day increasing. So we will see all our patients, most of the patients who are landing up in dialysis or kidney transplant because of diabetic kidney disease. So today I am going to talk to you about incidence, prevalence, and what is the management plan for the diabetic kidney disease. So nowadays, because of previously diabetic kidney disease is labeled as diabetic nephropathy, but it has been terminology recently has been changed to diabetic kidney disease because the lay people should understand it is very difficult to tell them you are having diabetic nephropathy, but if you tell them diabetic kidney disease, they will understand much better. So this is the worldwide diabetic cases which are just, this is published in the Lancet journal that the incidence and prevalence of the diabetic patients, that in top 10 countries, one of the first country is the India. We have maximum prevalence of diabetes cases. In 2030, the India will be again the topmost country. The prevalence of diabetes will be 79 millions. So India is the first country and China is the second, where the prevalence of diabetes is highest. So obviously we will going to see and treat all the patients with diabetic kidney disease and the complications which are produced by the diabetes. So this is a small thing about type 1 diabetes, as we see very few number of type 1 diabetes as compared to the type 2 diabetes. The 20 to 30% of the patients approximately after 10 years of type 1 diabetes, they will develop microalbuminuria. As we all know, the microalbuminuria is the first stage of diabetic kidney disease. Once the microalbuminuria starts, patients will progress to the macroalbuminuria, which is defined as a proteinuria more than 300 milligrams albuminuria per day. Once the macroalbuminuria develops, the type 1 diabetic patients, they will relentlessly progress to the end stage renal disease. That time they may require dialysis or kidney transplant. So usually the onset of diabetic kidney disease in type 1 diabetes will start after the 10 years of duration of the type 1 diabetes. So if the patient doesn't have proteinuria after 20 to 25 years of the type 1 diabetes, less likely they will produce diabetic kidney disease. This is just in type 2, what we see in our day-to-day practice, maximum number of cases are type 2 diabetes. This is one UKPDS study where they enrolled 5,100 patients of type 2 diabetes. And they have seen that if patient with no nephropathy, those patients who are having type 2 diabetes, 2% will progress to the microalbuminuria. If we don't treat, then 2.8% will produce to the obvious proteinuria, that is macroalbuminuria, and 2.3% people will ultimately land up in elevated creatinine levels and diabetic kidney disease, and they will require some form of the renal replacement therapy. As we see, the patients who are developing microalbuminuria, the incidence of death will progressively increase. Like no nephropathy, the risk of death will be the 1.4%. If they have microalbuminuria, there will be 3% risk. If albuminuria, 4.6%. Once they land up in end stage renal disease or they will require dialysis therapy, the mortality will be 19%. So we'll just go through how diabetes will affect the kidneys. So there are three major pathologic changes in the kidneys. One is the mesangial expansion, glomerular basement thickening, and glomerular sclerosis, which we learned in our pathology in second year that it is called as Klimelstiel-Wilson's lesions. This is the normal glomerulus, which is the electron micrograph of the glomerulus. These are the podocytes. This is the glomerular basement membrane, and this is the endothelial cell lining. This is the normal glomerulus. Next. In this slide, we see that glomerular basement membrane is thickened. This is the which is the earliest manifestation of the type 2 diabetic kidney disease. So any diabetic kidney disease, first thing they will develop is a glomerular basement membrane thickening. Next. Another thing what histopathologically we see is mesangial expansion. This is the normal glomerulus. The mesangial amount in this normal glomerulus will be minimal. But if compared to in this slide, there is a mesangial expansion. You can see these pink areas which are expanded. Next. This is a classic nodular lesion, which is Klimelstiel-Wilson's nodule. It usually, if methenamyl silver staining, you can find it very clearly. This is the pathognomic feature of the diabetic kidney disease. How it will affect, how the type 2 diabetic patients with uncontrolled blood sugar will have diabetic kidney disease. What are the mechanisms? One of the mechanism is glomerular hyperfiltration. I will explain you how it occurs. And the if patient sugars are not controlled, if uncontrolled blood sugars, this hyperglycemia, it combines with the amino acids in the proteins and produces that extra sugar which is present, it will combine with the amino acids and produce advanced glycosylation products. That is one of the mechanism for mesangial expansion. There is another proposed theories, the plasma protein activity will be increased and hypoxia, inflammation and activation of the cytokines. This is another mechanism for diabetic kidney disease. This is the normal glomerulus, this is the afferent arteriole, this is the efferent arteriole. If you compare in the diabetic kidney disease, the afferent arteriole will be the dilated and efferent arteriole will be the constricted. So what happens is the blood flow will go into the glomerulus, but if it is constricted, the pressure inside the glomerulus will go up and it will damage the glomerular filtration barrier. What we have seen is glomerular basement membrane and podocytes and endothelial dysfunction. All these things will damage because of increased pressure, and you will see proteins are coming into the Bowman space and you will have proteinuria. These are one of the mechanisms they have shown. There are multiple mechanisms, but these are the hormones like insulin like growth factor, atrial natriuretic peptide. These hormones will cause there is dilatation of the afferent arteriole, and this is the enzyme which is called aldose reductase. So these are the mechanisms why the glomerular hyperfiltration which will produce the diabetic kidney disease. So one of the mechanisms are hormones, another mechanism is sorbitol, which is present. Extra sugar will enter into the cell and it will, by aldose reductase pathway, it will convert it into the sorbitol and which will damage the tissue. These are advanced glycosylation products, that excess glucose which is present in the blood will combine with the amino acids and it will produce advanced glycosylation products which will cause the glomerular damage like mesangial expansion, glomerulosclerosis. So how this is just now I explained, this is by hyperglycemia and advanced glycosylation end products, they will cause mesangial expansion, increase matrix production into the glomerulus. Another thing is activation of protein kinase C and upregulation of the heparinase, which will damage the glomerular basement membrane and you will get the proteinuria. This is one of the mechanism, they say increased plasma prorenin activity, which causes increased expression of the vascular endothelial growth factor expression, and there will be the glomerular damage and it will damage the glomerular filtration barrier. This is another hypothesis, they say that I have shown you the glomerular filtration barrier. It is the endothelial cell, glomerular basement membrane, and these are the podocytes. Whenever the pressure in the glomerulus increases, it will stretches the podocytes, and podocytes gets detached from the glomerular basement membrane, and these podocytes will, if they get detached, they will undergo apoptosis and the filtration barrier will get damaged. So in patients with diabetic kidney disease, either there will be defect in the endothelium, either there will be defect in the glomerular basement membrane, or podocytes gets damaged. All these three things will cause the proteinuria and progression of the kidney disease. What are the risk factors for diabetic kidney disease? This is hyperglycemia, hypertension, duration of diabetes. Longer the duration of diabetes, more chance that you will get the diabetic kidney disease. Sometimes dyslipidemia, which will cause endothelial damage, as we all know, it causes atherosclerosis and macrovascular diseases. Obesity causes hyperfiltration and causes diabetic kidney disease. Smoking is one of the factors for progression and increased progression of the diabetic kidney disease. Usually lower socioeconomic group will have poor control of blood sugars and they will not control the diet. Those people are also most likely will end up in diabetic kidney disease. There are some genetic susceptibility. If patient family history is there, diabetes and diabetic kidney disease, then the next generation who are having diabetic, they will more likely to get diabetic kidney disease in further generation. These are the genes responsible, that is angiotensin converting enzyme gene as well as angiotensin 2 type 2 receptor gene, that will, if these genetic susceptibility are there, then diabetic patient most likely will land up in diabetic kidney disease. So how to diagnose? This is one of the screening tests for the diabetic kidney disease, that all diabetic patients we should check for urine albumin to creatinine ratio. What we say is microalbuminuria, by definition it is 30 to 300 milligrams per gram of creatinine. Normal is less than 30. So 30 to 300 is microalbuminuria, more than 300 is a macroalbuminuria. Sometimes if some lab is testing milligrams per millimole, then range will be 3.4 to 34. So this screening test should be obtained in the first morning urine sample, midstream urine samples early morning. The patient has to screen for albumin creatinine ratio. At least 2 we have to check for thrice. Out of 3 samples, if 2 samples suggest microalbuminuria, then we can label patient is having early diabetic kidney disease. So at least 2 out of 3 specimens are required to label the patient is having diabetic kidney disease over a period of 3 to 6 months. So 3 samples over a period of 3 to 6 months, they will have diabetic kidney. If microalbuminuria is there, then we can label them as a diabetic kidney disease. So why to just take a protein creatinine ratio rather than estimating the 24-hour urine protein, which will be the more accurate way. But it is very difficult to tell the patient to collect the 24-hour urine sample, because just for screening, and it will be very difficult to tell the patient to collect from morning 8 to next day 8 o'clock, you collect 24-hour urine sample. So just will by urine, spot urine, that is early morning midstream urine sample for albumin creatinine ratio, that ratio will approximately tell you the 24-hour urine proteins. That label will be correlated with the albumin creatinine ratio. So this is the graph they have compared. On this axis, this is protein creatinine ratio, and this is 24-hour urine proteins. So if you see, they are approximately correlated well. That's why for screening we tell them urine spot protein creatinine ratio rather than 24. If you find very high proteinuria, then you may ask them 24-hour urine protein levels. So how to detect that proteinuria? What is the methods used? This is the urine dipstick method. Usually it detects the albumin. It will not detect the other proteins like globulin, which will be present in the urine. It is very highly specific, but not very sensitive. That is the most important thing, because if protein, that dipstick will detect the protein if it exceeds more than 300 to 500 milligrams per day. But what our definition of microalbuminuria is 30 to 300. So if you want to detect these patients in early stage where we can intervene and treat them, so this 300 level will detect at the level of macroalbuminuria or once advanced stage of kidney disease. So it is very insensitive method for to detect early kidney disease. Once the proteinuria exceeds 300, then only it will detect. So what is the guidelines? 2007 KDOQI guidelines, that this is the guidelines, standard guidelines followed by all over the world, that all type 2 diabetic patients should be screened for microalbuminuria so that we can detect early and treat it early. Yearly screening for microalbuminuria is recommended, irrespective of, sometimes patients will ask you, I don't have any symptoms, I don't have any kidney problem, my urine output is good, there is no swelling, there is my appetite, nausea, vomiting, nothing is there, why should I check for the kidneys? So that is the problem, because we have to detect these patients in very early stage. If you want to detect them, the best method is to do investigation rather than waiting for the symptoms to develop, because as we all know, symptoms will develop once 80% of kidneys are damaged. That stage, I think intervention will not help to revert that back to the normal stage, because microalbuminuria, we can revert that kidney disease back to the normal. That's why we have to screen them. And that is in type 1 diabetes, we have to screen. If they don't have at the presentation, like at the time of presentation, no microalbuminuria, we can defer for 5 years after the onset of type 1 diabetes. In type 1 diabetes, we know exact time of onset, but type 2 diabetes, we don't know. Sometimes they come very late by chance or by routine checkup if they get detected diabetes, but we have to check them at the time of diagnosis as well as for every yearly. In type 1 diabetes, after 5 years of onset, we should screen them regularly for the proteinuria. That's it. So what is the creatine? Just a few words about creatine. Creatine is very poor marker of kidney filtration, that is glomerular filtration rate, poor marker of GFR. Why? Because the creatine levels will change according to the dietary intake. It will change according to the muscle mass. If you take high protein diet, the creatine will be little bit on higher side. If the patient, creatine is primarily synthesized from the creatine which is present in the muscles. So if patient is having low muscle mass, the creatinine will be always low. If suppose someone is having a big muscle mass, is a athlete or is a wrestler, his creatine will be little bit on higher side. So that it will variation according to the muscle mass as well as the diet. Another thing is, what happens, creatine is not a exact marker of GFR, because if GFR goes down, some amount of the creatinine will be secreted from the tubules into the urine. So the GFR will not reflect, that creatine clearance will not reflect the GFR. It is little bit always on a higher side as compared to the GFR, because GFR inulin is the exact substance which will estimate the GFR. But creatine, as part of the creatine is filtered and part of the creatine is secreted into the tubules, so the total creatine clearance will be little bit on higher side. So it is not reflecting exact glomerular filtration rate. Even if glomerular filtration rate decreases, there will be increased secretion from the tubules. So it will not reflect the exact glomerular filtration rate. Sometimes different labs will use different methods. So there is differences in method and equipment also will change the creatine value. And certain substances like alkaline picrate method, which is substances like that will interfere with the alkaline picrate method, which is modified Jaff's kinetic method, which is used for the creatine estimation. So these substances will interfere with that, and the patient will have different creatine values. So it is varies from lab to lab. This is one of the standard method which is recommended by the KDOKI people. This your creatine method has to be standardized to isotope dilution mass spectrometry, creatine reference method. This is the creatine reference method. Every lab should check the creatine with that reference method and then give the creatine value. So another thing to, because if we can adjust the, because creatine, as I told you, it will change with the age, muscle mass, dietary protein. If there is a formula like Cockcroft-Gault equation or MDRD equation, so you can tell your lab to give the GFR value according to the age, sex, height, weight. So if you can give them body weight, age and sex, they will give exact GFR value, that is creatine clearance value, which will reduce the variations caused by the dietary protein and age and muscle mass. Next, this is just I said, because creatine will not reflect the exact GFR value. What has happened is normal GFR is 120 and at that creatine is supposed to be 1. But if you take GFR from 120 to 60, your creatine value will be 2. So almost 50% kidneys have gone, then your creatine is 2 only. So sometimes people may say my creatine is just 2, but that is very bad thing, because already you are lost your 50% of the GFR. So that's why we say creatine will not reflect the exact severity of the reduction or the severity of the kidney damage, how the GFR has gone down. So from 120 to 60, like 50% reduction GFR, your creatine is only 2. So it is a very serious problem. Even if slight rise in the creatine, it will reflect marked decrease in the GFR. So we should always advise to our lab to give Cockcroft the GFR estimated equations. These are the equations which are used, Cockcroft-Gault equation and MDRD-Gault. So only these equations should be used only in patients with a stable kidney function. We can't use in the acute renal failure in ICU patient where day-to-day variations of creatine will be there. So usually in ICU patients in acute kidney injury, we take GFR less than 15 ml. We don't calculate. Those equations are there for chronic kidney disease patients where GFR is stable. It will not change daily. This is the new equation that has come up, CKD EPI equation. This is used for the general population who have GFR more than 60 ml per minute. This is a revised CKD classification. They have staged, previously it was stage 1, stage 2, stage 3, stage 4. Now they have divided according to the GFR, that is G1, G2. So according to the GFR value which is calculated by MDRD equations, they have divided from G1 to G5. And they have taken proteinuria as one of the criteria. Previously they have not accounted for the proteinuria. Now they have seen A1, A2, A3, they have labeled as less than 30, 30 to 300, more than 300, A1, A2 and A3. So they have given importance to the proteinuria also. So just diabetic kidney disease, suppose if patient is have diabetes, we can't every time the GFR goes down or creatine goes up, we should not label every time it is a diabetic kidney disease, because there are a lot of diseases which are non-diabetic kidney diseases which will occur in the normal population who are also non-diabetic. So we have to differentiate from the diabetic kidney disease and non-diabetic kidney disease like other diseases which will affect the kidneys. These are the one of the clues, like if the patient is having proteinuria less than 5 years from the onset of type 1 diabetes, or if patient is having type 2 diabetes, and in type 1 diabetes we know exact onset of the disease. In type 2 diabetes we don't know, just it will get detected if they have family history, routine screening, they will get type 2 diabetes known. So in type 1 diabetes, if onset of proteinuria less than 5 years after the onset of disease, then we should suspect non-diabetic kidney disease rather than diabetic kidney disease, because for to develop diabetic kidney disease, the duration of diabetes should be at least 5 to 10 years. If someone is developing before that, that means we should suspect something other than a diabetic kidney disease. If patient is having acute onset of kidney disease, usually the diabetic kidney disease will be slow and progressive. It will not suddenly come in a 1 day or 2 day, weeks or months. It will take 6 months to 1 year to develop diabetic kidney disease, and it will progress very slowly. If someone is having sudden onset of acute kidney injury, then we should suspect non-diabetic kidney disease. If patient is having, apart from proteinuria, if patient is losing blood, like RBCs are present in the urine, then we should suspect non-diabetic glomerular diseases. If type 1 diabetes, if they don't have retinopathy, usually in diabetic patients, once they will start diabetic kidney disease, they will also have diabetic retinopathy. So always check for the diabetic retinopathy. We can tell the patient, visit your ophthalmologist to check for the fundus to see any changes are there in the diabetic, evidence of diabetic retinopathy. If they don't have diabetic retinopathy and they are having proteinuria and duration of diabetes is very small, like less than 5 years, then we should suspect, oh, this may be something non-diabetic kidney disease rather than diabetic, because diabetic retinopathy and diabetic kidney disease always goes hands in hand. Sign, if the patient is having joint pains, skin rash, any other which is not particular to the diabetic patients, like we should suspect non-diabetic glomerular disease, vasculitis, joint pains, skin rash, hair loss. These things will present with the non-diabetic glomerular diseases. If there is sudden, that's why I told you, if GFR is suddenly reduced, because it will not be going down in suddenly in a type 2 diabetic patients. If there is more than 30% loss of GFR within 2 to 3 months after administration of ACE-ARB, I will discuss with this thing ACE-ARB, what is the evidence for giving ACE inhibitors, ARBs, and if you start these patients on ACE or ARB, ACE inhibitors and ARB, and GFR goes down more than 30% reduction is there within a period of 2 to 3 months, you should suspect non-diabetic kidney disease. This is what the natural history of diabetes, diabetic nephropathy. You see, this is a microalbuminuria level, and this is the overt, like more than 300, we say it is a macroalbuminuria. 30 to 300, we say it's microalbuminuria. So how it will progress? If this is the duration of the diabetes, suppose approximately at 5 years, they will have microalbuminuria. Then it will progress, it will cross the macroalbuminuria. This proteinuria will go on increasing. If you compare this proteinuria, if you compare this GFR, normal GFR is 100 to 120, that's what I told you. The GFR, as the proteinuria goes up, the GFR will come down. That means kidney function is going down as the proteinuria goes up. So that is how the patients will land up approximately 25 to 30 years if GFR is going down, and they will land up in the end stage renal disease. So this slide will explain the albuminuria. As it increases, GFR will come down. So how can we prevent the decrease in glomerular filtration rate in diabetic kidney disease? First thing is we have to control the sugar levels, because as I discussed in pathogenesis, that uncontrolled blood sugar will produce the whatever the pathologic changes and reduction in GFR, proteinuria. First thing is we have to control the sugar, and we have to target that glycosylated hemoglobin levels to less than 7%. Now suppose someone is a diabetic, he doesn't have a blood pressure, he doesn't have a proteinuria. Now we want, that patient wants, I should not develop diabetic kidney disease. Apart from whether we should treat such patients in advance so that they will not develop future diabetic kidney disease. So whether any evidence is there. This is one trial, ABCD trial, normotensive appropriate blood pressure control in diabetes. In this trial, what they have taken, they all diabetic patients who don't have blood pressure, who don't have proteinuria, and they have treated these patients with ACE inhibitors or ARB so that in future they should not develop proteinuria. But they have seen, is there is no benefit of developing proteinuria, microalbuminuria or macroalbuminuria. Even before developing the proteinuria, if we treat them, there is no benefit as compared to those patients who have not treated and those patients who have treated. So what they have recommended is, do not treat with ACE inhibitor or ARB solely to prevention of the microalbuminuria in these patients. So they should be screened yearly for the proteinuria. Once they develop proteinuria, you should treat them. If there is no proteinuria, BP is normal, don't treat them, just screen yearly. So it is not going to change the outcome if we treat in advance before they develop the proteinuria. Suppose the same patient, type 2 patient, diabetic patient, they don't have proteinuria, but they have hypertension. Whether to treat such patients? Now these are the two trials, Benedict trial and roadmap trial. What they have done is, those patients we have in Benedict trial, the baseline blood pressure was 150 by 80. They were randomly assigned trandopil, that is ACE inhibitor, verapamil calcium channel blocker, and the one placebo, and they have compared the whether they will develop microalbuminuria, how much time they will take it will take to develop microalbuminuria after 3 years. So they have shown that the incidence of microalbuminuria after 3 years of follow-up was less with the trandopil. So such patients we can treat with ACE inhibitor or ARB who are hypertensive with no proteinuria, because we can prevent them developing in future proteinuria. The similar trial, roadmap trial, they have taken 4,000 patients of type 2 diabetes. We have blood pressure of 136 by 81, and they are treated with olmesartan and placebo. Olmesartan is ARB. So olmesartan was associated with reduction in the blood pressure, and there is a incidence of developing microalbuminuria is very less. So such patients who are hypertensive with no proteinuria, type 2 diabetic patients, we can treat with ACE inhibitors or ARB. So this was a prevention of proteinuria. Now how to treat? Once they develop proteinuria, what are the plan of management? Like first thing I already told you, sugar control is the basic first thing. We have to control sugar strictly to target glycosylated hemoglobin less than 7%. We have to control the blood pressure. We have to restrict the proteins. We have to tell them to reduce the weight. Weight reduction is again another. I will explain each of these points. And hyperlipidemia. We have to treat the cholesterol levels, LDL levels to prevent the diabetic kidney disease. Now why glycemic control? One thing is, whether is it going to really help if we control the sugars, whether it will prevent or it will prevent the progression of the diabetic kidney disease once they develop or whether we can revert it to the normal. So what is the evidence for that? So how glycemic control will help? It will reverse the glomerular filtration, hyperfiltration. It will reverse the glomerular hypertrophy. It delays the development of the albumin excretion, and if patient has proteinuria, it will stabilize the proteinuria. It will not progress further if we control the sugar strictly. This is the slide. They have done, this is one trial in a small number of patients. What they have done, they have taken 8 patients with type 1 diabetes who has histological evidence of diabetic kidney disease. They have glomerular basement thickening, tubular basement thickening, there is increased mesangial matrix. So they have proven these 8 patients with type 1 diabetes with kidney biopsy they have developed diabetic kidney disease. Now what they have done is, they have done pancreatic transplants in this patient so that it will replace the insulin which is present exactly in the normal way. Like they have taken type 1 diabetic patients and they have put the islets like pancreatic transplant which will replace the insulin. So what they have compared is, after doing that pancreatic transplant, that is strictly glycemic control, another way, they have seen that all the histological parameters are reversed. That patients having diabetic kidney disease, after strictly controlling their sugar levels by pancreatic transplants, all the histological features which are present, it has reversed to the normal. So that is the evidence we have. If we control the sugars, we can control the diabetic kidney disease. If we can prevent them, we can prevent the progression once they develop the diabetic kidney disease. So this is one parameter we use whether patient is strictly glycemic control or not. This is called glycosylated hemoglobin. So extra glucose which is present in the blood in uncontrolled type 2 diabetic patient, it will combine with the hemoglobin and it will produce glycosylated hemoglobin levels. So, but problem with this is in kidney failure patients where creatinine is high, it will be falsely elevated or decreased. But on an average, this is the best method, because there are some false elevations. Which method they use for glycosylated hemoglobin, that will also interfere with the protein. If glycosylated hemoglobin, if patient is having high creatinine value, there will be the false elevations, and sometimes false decrease will be there because in dialysis patient the RBC survival, the lifespan of RBC is decreased, so it will also false decrease levels will be there. But still we use, because we don't have any other method to check for the strict glycemic control in diabetic kidney disease. So this is one of the well-known trial type 2 diabetes in UKPDS study. what they have taken 4,000 patients with type 2 diabetes patient. They have targeted. So we are now thinking about what is the evidence, what level it should be good so that we can prevent the progression of diabetic kidney disease. If glycosylated hemoglobin, these are the two groups. In this group they have targeted 7.9, in this group they have targeted 7% of glycosylated hemoglobin, that is intensive group. This is a conventional group. Next. So they have shown that there is a 25% reduction in development of microvascular disease, which is defined as renal failure, death from renal failure, and all other retinal complications also decrease in patients with intensive sugar control as compared to conventional. Intensive, we targeted glycosylated hemoglobin less than 7%. So we have evidence if you control sugar strictly, we can prevent the progression of diabetic kidney disease. So whatever the method you control the blood sugars intensively, whether insulin or sulfonylurea, so there will be lesser risk of developing microvascular complications like diabetic kidney disease, diabetic retinopathy. So these are the all intensive treatment. Problem is if you control too strictly, the patients may land up in hypoglycemia. That is another problem. Now what they have done in ACCORD trial, they have reduced from 7% to 6%. They want to strictly control more strict control. Now they have targeted with glycosylated hemoglobin with less than 6%, and they have compared whether it is going to improve more improvement as compared to the previous trial. Next. So what happened is if you control too much, there are high incidence of hypoglycemia. There is high risk of fluid retention. They have gained significant weight. So most important problem is if you control glycosylated hemoglobin target less than 6%, there are high chance of hypoglycemia. So they have cut off point, they have kept it at 7%. 7% has significant. If you reduce too much, then the patients will land up in hypoglycemia. There is an increase of cost also, and there is a risk also. If patient is left untreated, they may develop brain damage. So what they have shown is if you strictly the same trial, ACCORD trial, if you control their blood sugar strictly less than 6%, there is increased incidence of mortality. So patients with events, you see intensive therapy will have higher incidence of complications like hypoglycemia. Next. So what is the recommendation is improved glycemic control will improve the microvascular complications. Type 2 diabetes, the target glycosylated hemoglobin level should be less than 7%. Problem with chronic renal failure like chronic kidney disease, once creatinine goes up, the patients may have insulin resistance. They may have insulin, like if kidneys are one of the organs which will degrade the insulin, so there is a decrease insulin degradation, so insulin requirement may go down also. So we have to target the insulin to exactly match that glycosylated hemoglobin should be less than 7%, not too low, not more than 7%. So what are the drugs which are recommended in once the patient develops diabetic kidney disease, like GFR has gone down, so which are the drugs we should use? This is one glipizide drug is the drug of choice among all the oral hypoglycemics because it is metabolized in the liver and it is primarily excreted in the urine as inactive metabolites. So it is the drug of choice. Other oral hypoglycemics after metabolism, they may have active metabolites which will cause hypoglycemia. So these drug, they will have inactive metabolites. So it can be safely used in diabetic kidney disease patients, or we can use low dose of glimepiride also can be used in patient with diabetic kidney disease to control the blood sugar. Another group of drug is acarbose, alpha glucosidase inhibitors. It is not recommended because some amount of these drugs will get absorbed from the intestine and it will accumulate in the body. So it is not recommended. Another thing is pioglitazone, rosiglitazone. There are high incidence of edema. Already CKD patients, they will have fluid overload and heart failure chances will be high. So these patients, there are high risk of edema, heart failure. Recently they have shown it is associated with bladder cancer and incidence of fractures. Another drug, ripaglinide, it is a short acting, it will secrete insulin. It can be used because its half-life is too low and it is metabolized in the liver. So it is used, it can be, ripaglinide can be used for the sugar control in diabetic patients. So we can use glipizide, low dose of glimepiride or ripaglinide. These are the new drugs, that is GLP-1 analogs, then exenatide and liraglutide. So these are the new drugs you should remember. Nowadays I think they will come into the market and we will start using these drugs. They are only in injectable form. It will come in the pre-filled syringes. As far as exenatide is concerned, it produces there are reported cases of acute kidney injury, and there are increased incidence of GI side effects like nausea, vomiting, loose motions. So it should not be used if GFR is less than 30 ml per minute. We can use it safely if GFR, that calculated GFR according to the creatine clearance, if it is 30 to 50 ml per minute, we can use, but we have to use with caution. Liraglutide doesn't require any dose adjustment. In fact, it is associated with the weight reduction also. It also comes pre-filled syringe and once daily. Exenatide is twice daily dose, liraglutide is once daily. So patient compliance will be better, and there is no dose adjustment in kidney patients. So liraglutide we can use. These are the DPP-4 inhibitors: sitagliptin, saxagliptin, vildagliptin. Now linagliptin is also going to available. So sitagliptin, we have to adjust the dose in kidney patients according to the GFR. If GFR is more than 50 ml, no dose adjustment. 30 to 50 ml, we have to give 50 milligram once daily. If less than 30 ml, we have to give 25 milligrams once daily. Similar to saxagliptin. Only thing is saxagliptin is dialysable drug, should be given only if those patients who are on dialysis, we should give after dialysis, not before. There is incidence of acute pancreatitis with these gliptins, sitagliptins, saxagliptins. We have to monitor really if patient is having abdominal pain, those who are on these drugs. So we have to screen for pancreatitis because it produces pancreatitis. Linagliptin is the drug which will not require the dose adjustment, and it is a 5 milligram once daily dose. So linagliptin, once it is available, we can use in chronic kidney disease patients because it doesn't require the dose adjustment. We can use it freely. Vildagliptin is not approved in US. It is used in European countries. Its dose adjustment is similar to sitagliptin. Now, as far as metformin, this is American Diabetic Association's guidelines. So what they say is metformin, and in US and UK they follow different protocols. In US, if creatinine is more than 1.5 in males and 1.4 in females, they will stop metformin. In UK, they will decrease the dose if GFR is less than 45 ml and stop if GFR is less than 30 ml. So we'll go ahead. Now we have seen the strict glycemic control, how it will prevent the progression of CKD. Now whether we can protect, what is the evidence whether we'll give these ARBs, angiotensin II receptor blockers, how it will prevent the progression of CKD. So renal protection with ARBs. This is one trial, this is a well-known trial, IDNT trial, irbesartan diabetic nephropathy trial. What they have recruited is 1,715 patients, hypertensive patients with proven diabetic kidney disease where creatinine was more than 1.7, and they have treated with irbesartan, amlodipine and placebo, and they have compared whether, and they followed up also. So sometimes we may say it may be because of better blood pressure control they have not progressed. So whether you control with irbesartan or whether it control with the amlodipine, blood pressure control, that's why. But they have shown apart from the blood pressure control, irbesartan like amlodipine, placebo and irbesartan. These are the 4 different groups which will have different blood pressure ranges. But if you see, relative risk of renal endpoint was very much less in the irbesartan group as compared to amlodipine group. So irrespective of blood pressure control, the irbesartan, the relative risk of renal endpoint was less. That means ARB has, apart from blood pressure control, ARB has good protection for progression of CKD. So what 2.6 years follow-up, they have shown that irbesartan was associated with risk of renal endpoint 23% and 20% lower than the amlodipine group and placebo. So there was a significant reduction of renal failure or renal endpoint in patients who are on irbesartan group. So these benefits were independent of the blood pressure control. And the renal, this was just another finding, the best outcome where the blood pressure is less than 134, they have found the bed outcome was the best. This is another trial, renal trial, where they have shown the similar benefits with the ARBs as compared with the placebo. They have took 1,513 patients with type 2 diabetes with nephropathy, and they have followed for 3.4 years. So, and they have shown there was significant risk like doubling of serum creatinine, that is progression of the serum diabetic kidney disease was very less in losartan group as compared to the placebo. Next. This is like how they are correlated with, in the same study, in renal study, they have shown that proteinuria, if we keep it at lower range, the risk of renal endpoint or progression to end stage renal disease was very less. like if patient is having lower proteinuria, lower risk to reach the renal endpoint and progression to the end stage renal disease. So apart from ARB, that ARB, what ARB does it to reduce the proteinuria. If you keep the proteinuria very less, then progression of CKD to the end stage will be less. This is same group that change of level of proteinuria was significantly lower with the losartan as compared with the placebo. Then another question is whether which is more better, ACE inhibitors or ARB. So this is another trial, detailed trial. They have compared enalapril with telmisartan in 250 patients with diabetic kidney disease, and they have compared whether with which group of drug will have significant retardation or progression of chronic kidney disease, diabetic kidney disease. Next, so the change of glomerular filtration in both the group of drugs like enalapril versus telmisartan was almost equal. So they have not, no other one drug is more benefited or than the other drug. So both are equally effective in progression. Next slide. The blood pressure control was almost equal in both the groups. So the change in serum creatinine in telmisartan group and enalapril group almost equal. There is albumin excretion rate is also equal. So results are consistent that ACE inhibitors are equally effective with the ARB. So no one drug is more benefited than the another drug. So either you can use ACE inhibitor or ARB. Both are equally effective. Next, and this is whether we can use combination of ACE inhibitor or ARB for much reduction of proteinuria and progression of chronic kidney disease. What they have done in on-target study, they have compared telmisartan, that is ARB, ramipril ACE inhibitor, and they combined ACE inhibitor plus ARB, and they have seen all these three groups whether combination will give us the maximum benefit. But they have found that combination therapy there is high incidence of renal impairment. The renal failure requiring dialysis was high in combination group as compared to the individual group. Next, they have high incidence of hypotension and high incidence of renal impairment in the combination group. So we don't advise to combine ACE inhibitor and ARB because it is giving a lot of complications. Either you use ACE inhibitor or ARB, but never use the combination. Next, this is a few other trials which can be just aliskiren, we all know, direct renin inhibitors. They have combined with losartan in AVOID trial to see whether we will get maximum benefit for progression of diabetic kidney disease. But they have found that it is beneficial as compared to losartan alone, but there are high incidence of hyperkalemia, and there was so the aliskiren plus losartan both is more effective, 20% beneficial as compared to losartan alone, but there are high incidence of hyperkalemia in this trial. Another aldosterone antagonism, it also reduced the proteinuria. They have combined with ACE inhibitor or ARB, but hyperkalemia is another risk factor if you combine aldosterone antagonists like spironolactone and epinephrine. These are the drugs diltiazem, verapamil. They are as effective as ACE inhibitor. If patient doesn't tolerate ACE inhibitor or ARB, we can try these drugs of diltiazem and verapamil. They are shown equally beneficial and they reduce the proteinuria. What is the goal blood pressure? That what blood pressure, like as we seen in the glycemic control, what target glycosylated hemoglobin we should achieve. Similarly, what blood pressure control, like what is the blood pressure level in these patients which will give the maximum benefit. Next, this is the ACCORD BP trial. They have compared the systolic blood pressure of 133 as compared to 119. So this is intensive blood pressure control, this is a standard blood pressure control. So they have lowered the blood pressure to 119 and they have followed up these patients whether we will get the maximum benefit. Next, so in patients with type 2 diabetes with high risk of cardio, targeting systolic blood pressure less than 120 as compared to less than 140 does not make any difference. They do not reduce the cardiovascular events or progression of kidney disease. So all diabetic patients should have good blood pressure control less than 140/90. We should not reduce too much also, it will cause hypotension, all other complications, and it is not beneficial from cardiovascular point of view. So goal blood pressure should be 130/80 in patients with diabetic kidney disease. All diabetic patients we should target blood pressure less than 140/90, but those patients with diabetic and diabetic kidney disease who develop proteinuria, those patients we should target less than 130/80. It should not be targeted less than 120, as we have seen there is associated with a lot of complications. These are the average in different studies, average number of medications which are required for the blood pressure control in diabetic kidney disease patients. So, on an average you will require 3 blood pressure medications to control the blood pressure to reach that goal. So, if someone diabetic kidney disease patient, if it tells you my blood pressure is well controlled with only one medicine, then you have to really doubt whether blood pressure is adequately controlled or not, because it will require at least 3 medications to achieve that goal in diabetic kidney disease patient. Another thing is we restrict the proteins in diabetic kidney disease patients to prevent the progression, as high protein diet they say it produces glomerular hyperfiltration and it will progress the faster diabetic kidney disease and will progress much faster in high protein diet patients. But it is very difficult to achieve the low protein diet because difficulty to adjust the diet, difficulty with compliance, and these patients may have land up in increased risk of protein malnutrition. Next, this is one trial. They have shown dietary protein restrictions in CKD patients, diabetic kidney disease patients. So they have change in GFR was less with the low protein diet as compared to the high protein diet. So there was if those patients, these are the type 1 diabetic patients. These are the 2 trials they have compared with the low protein and high protein diet. So low protein, there was significant reduction in the progression of chronic kidney disease. How to control the lipid levels in diabetic kidney disease patients? This is the target LDL levels in CKD stage 1 to 4, as was seen in according to glomerular filtration rate. We have divided the stages. Stage 1 to 4, it should be less than 100 milligrams per deciliter. If stage 1 to 4 and LDL cholesterol more than 100, we can treat with the statins, but we are afraid that patient will develop rhabdomyolysis if creatinine is very high. But there is no evidence of higher rhabdomyolysis in these patients, so we can treat with the statins. No statins in patients who land up in end stage renal disease unless they have some cardiovascular disease, coronary heart disease, then we can give with the statins. Otherwise, don't treat these patients prophylactically in end stage renal disease. No statin should be used. It is proved in SHARP study. We have to reduce the salt intake. How the salt intake reduction will help to reduce the proteinuria? Because high salt intake was shown to blunt the antiproteinuric effects of angiotensin receptor blockers, angiotensin inhibitors, ARBs and ACE inhibitors. It blunts the response of proteinuria, how they produce the proteinuria. If you take high salt diet, the effect will be less. As you know, obesity and overweight will produce glomerular hyperfiltration. So weight reduction will be helpful. So these patients will have less glomerular hyperfiltration and less degree of proteinuria. So weight reduction is always advised. So these are the recommendations. You should target the protein excretion to less than 500 to 1000 milligrams per day. We have to strictly control the blood sugars. We target the glycemic control less than 7%. For most of the patients, not less than 6%, it has to be 7%. You should target the blood pressure in diabetic kidney disease patient to less than 130/80, not less than 120, not more than 1. So you should always target the blood pressure with diabetic kidney disease patient to less than 130/80. ACE inhibitors and ARBs are equally effective. We can use either ACE inhibitors or ARBs. We should not use combination of ACE inhibitor and ARB. If diuretic therapy plus either ACE or ARB does not achieve the goal blood pressure, we can use non-dihydropyridine calcium channel blockers like diltiazem and verapamil. As we have shown, protein restriction helps in preventing the progression of diabetic kidney disease. So only thing, those patients who are having chronic kidney disease because of diabetes, if you start them ACE or ARB, we should monitor for the glomerular filtration rate and development of hyperkalemia. If there is 30% reduction of GFR over a period of 4 weeks, then we should stop the ACE inhibitor or ARB. These are the emerging therapies for the diabetic kidney disease patients. The main aim is for the reduction of proteinuria and how to increase the glomerular filtration rate. These are the protein kinase C. Roboxytaurin is a new drug which inhibits the protein kinase C. As I already told in the pathogenesis, it is one of the enzymes which produces the diabetic kidney disease. This sulodioxide alters the glomerular basement membrane. There is some vitamin D receptor activation, paricalcitol, endothelin A receptor blockage. These are the drugs which will reduce the proteinuria, and these are the drugs which will increase the glomerular filtration, like pyrifidone and anti-inflammatory drugs. Common theme is to reduce the inflammation which is produced by the different enzymes. Thank you. Next.